I'm Dr. Sadaf, and I'm going to deliver a short presentation on ultrasound-guided venous access. These are just few of my certifications. Okay, the highlights of my lecture. Our main focus will be on peripheral intravenous access and central venous access. I hope you can see the cursor moving. Yes, you can see. But we will also have a brief overview of the PIC line at the end of our at the end of this lecture, right? So about the peripheral venous line, we'll briefly go through the patient preparation, patient positioning, vein selection, cannula size, use of ultrasound for peripheral intravenous cannulation, step-by-step approach to ultrasound-guided peripheral intravenous access, and predictors of difficult IV access. So first of all, patient preparation and patient position. Now, as you can see, the patient should be lying supine. Patient should be comfortable. The arm should be placed on some side table or the armrest, and the ultrasound machine be just in front of the operator over here. And you can also add or some rolled towel under the arm for more stability and support. Now, these two pictures, it's about the position of the operator and the ultrasound machine. Now, these are self-explanatory pictures. If you compare these two pictures, which one do you think is more appropriate? I think, of course, this one on the right side, because operator should also be sitting comfortably, and the ultrasound machine should be in front of the operator, just in a line. The ultrasound machine and the operator should be in a line. While on this image on the left side, you can see this is very uncomfortable position for the operator. While standing, his hands will not be stable, and of course he will be having difficulty on looking to the screen on his left side or on his right side. So it should be just in front of the operator. So get your splice. You should have these few things on your tray, like IV cannula, swab, adhesive dressing, gauze, tourniquet. It can be a clipped tourniquet, or it can be just something else without a clip. And there will, and also you should have the three-way stoppers, with the reflex valve, and a flush with a normal line or distal water. Now about the how to apply a tourniquet, although it seems like it's a very easy thing and everybody knows how to apply a tourniquet. But when you're doing everything single-handedly and you're all alone, then of course you have to follow the standards or the standard protocols. Only one loop that can be pulled out with one hand. Do not try to make a knot. And the tourniquet should be flattened over the skin instead of bunched up. And this can be more comfortable, not only for the patient, but also for the operator. Now, this is a self-explanatory image in which you can see the tourniquet is looped, right? You have to make a loop. Do not make a knot. It's because you won't be able to open the knot when you are doing everything all alone. You're holding a probe in your hand. You're just inserting the needle. Then it will be very difficult for you to open the knot, right? Now, about the vein selection and cannula size. Again, it seems very like it's seem to be like veins. Why it's very important to know which vein to be selected and why the cannula size is very important. But let's have a look why these things are important. Now, a wide bore IV cannula is preferred. Veins with larger diameter, longer length IV cannula, and deeper veins. Why? Wide bore IV cannula, it's not a myth. Everybody knows, or most of us know about the Poiseuille's law. That is, the flow rate is directly related to the size or the diameter of the IV cannula. Then comes a vein with a large diameter. It accommodates larger and longer catheters, and usually basalic, brachial, and cephalic veins are preferred for IV cannulation. Longer length IV cannula, the length of the catheter should be sufficient enough so that the tip resides within the vein lumen, and the minimum length of 45 millimeter is often recommended. Deeper veins, why deeper veins? Deeper veins are preferred over superficial veins? It's because for the better anchoring, because the surrounding tissue will support and stabilize the IV cannula, thus reducing the risk of catheter dislodgement and less movement. Superficial veins roll under the skin, but the deeper veins are less prone to movement, making them easier to target while using ultrasound machine. About the scan probes, Dr. Nilofer has already very beautifully described the different characteristics of these probes. Just have a brief look why we should prefer hockey stick probe if we have this at our setup. But if you don't have hockey stick probe at your setup, then that's totally fine. You can use linear probe. The probe, both of these probe has high frequencies, but about the hockey stick, it has a smaller footprint and it allows improved probe contact between small irregular surfaces, and it improves the visualization. So that's why. But if you don't have, just don't be depressed, you can use a linear probe. No worries. About the probe orientation, again, Dr. Nilofer has already described it very well. It's just orientation. It's just a repetition of what Dr. Nilofer has already told. It's the transverse orientation of the probe. As you can see, the transverse orientation, while this is the longitudinal orientation of the probe. Moving on next. I think this is also covered by Dr. Nilofer. Just a brief repetition. So that's how the vascular structure will be visualized under your probe. When your probe is in transverse orientation, the whole length of the vessel will be visualized. But when your probe is in transverse orientation, only the vessel will be appear as a round structure. It will be appear with this cross-sectional area, and not the whole length of the vessel can be visualized. Now, this is the inline, and this is in plane and out of plane needle alignment. I think Dr. Nilofer already has discussed this. I just want to repeat so that just for reinforcement. As you can see, this is the in plane needle alignment. While using this approach, the whole length of the needle, as you can see, the whole length can be visualized. While using the transverse orientation, only the tip of the needle, as you can see over here, if you can see the cursor down here, only the tip of the needle will be visualized under the transverse orientation, right? So let's jump to the ultrasound guided step-by-step approach. So first of all, again, the patient should be lying supine, and while over here patient is sitting. Anyways, so patient should be lying spine comfortably. The arm should be on a side table. The probe is placed on the transverse orientation, as you can see. As all of you know, the direction of the needle, or the direction of the veins or the vessels, or the orientation of the vessels in the arm will be like this in the longitudinal way, right? So you will be putting your probe just like this on the transverse, and you will have an image like this, the rounded structure. This is the cross section of the vein or artery, whatever it is. We have to confirm that it's vein or artery. Now, this is a vein. As you can see, it is compressible. But if you apply pressure, the artery will not be compressed. So, just a second. So to differentiate between that the structure is whether it's an artery or it's a vein, you can just apply a little pressure and you will see the compressibility of the vein. But if you apply the pressure, the artery will not be compressed. Secondly, if you're in doubt that whether the structure is a vessel or the structure is something else, so you can just apply pressure just like this. Just squeeze a little the arm, and the blood will flow. The flow of the blood will increase over here, so that will confirm that it's at least it's a vessel, right? For that you and yes, for that you have to use the color flow option in the ultrasound machine. Now this is very important slide. I just want you to I just want you to take a screenshot of this. This is a very beautiful slide. Now it shows the relationship between the vein depth and the angle of the needle that it makes with the skin. Now let's focus on the bottom of the slide, like just over here. Let me use my cursor, a marker, so you can see. All right, so just have a look over here. Now, this is a standard length ultrasound IV line, and this is the ultra longer length ultrasound IV line. So we have different kind of IV cannulas, but most of I know at most of the places, especially in the public sector hospitals, we don't have the ultra longer length IV cannulas. We just have standard length IV cannula. So let's go with this. So over here, as you can see, now this is the basically the depth of the vein from the probe. This is this part, right? The depth of the vein. This is a vein. This is a probe. So this is the distance between the probe and the vein. So if the vein is at a distance of 0.53 centimeters from the probe, then the angle of needle insertion, should be 15 degrees for a successful prick of the vessel. If your vein is at a depth of 1 centimeter, your angle of insertion of the needle should be 30 degrees from the skin. And if it's 1.4 centimeter or more than 1.4 centimeter, just again, increase the angle from here, and it will be like about 45 degrees here from the skin, right? I hope I have made it clear. All right, next slide. So this is the out of plane technique in a transversely oriented probe in a patient, as you can see, and you can just appreciate that the round structure, this is a cross section of the vein. The operator is just inserting the needle by using out of plane approach. Okay, the next slide. This is a live animation, a live demo. This is the tip of the needle. You will not be able to see the whole length of the needle, right? In a transverse orientation probe, you will just have the tip, this dot over here, this little dot. This is the needle. It's just coming inside the vein. Now, this is the longitudinal orientation, as you can see here. Let me use the cursor marker. So as you can see, this is the longitudinal orientation, right? And you can see the whole length of the vein. You can see the whole length of the vein. So as the needle is inserted, stellate is removed, the catheter is forward. This is a very beautiful animation of how it works. Now coming to the predictors of difficult IV access. There are certain factors you may come across while passing the IV line under ultrasound guidance. There may be patient factors, and then there are vein factors. First of all, age. Infants and older adults, they have very fragile, thin veins. Obesity, edema, swelling can obscure the veins. Dehydration, shock, hypotension, emaciated body size, they can lead to smaller and less prominent veins. The chronic illness like diabetes, renal impairment, and cancer, these can affect the vein quality. And then anxiety and poor cooperation from the patient, especially in children, of course, it may cause difficulty while placing the probe. History of multiple IV cannulations already before and drug use can lead to venous scarring, and you will find it difficult to pass the IV cannula, or there will be no blood flashback or aspiration while passing the IV cannula. The vein factors, vein with many valves, these can impede the smooth insertion of IV cannula, and then sclerosed, hardened, or bruised veins. Of course, there will be difficulty in passing and forwarding the IV line. Now that was all about the IV access. Now let's have a brief look on the central venous access, the central venous line, the major blood vessels. Now I will briefly take you through the site selection, step-by-step insertion, and central line versus PICC line at the end. Again, site selection, the following factors are very important, and you should keep these factors in mind. Vein factors and the patient factors. About the vein factors, patency. Patency is very important. The vein should be patent. I will tell you what does that mean. And secondly, the thrombosis. If there is thrombosis, do not attempt at that vein. Size of the vein, more bigger the vein, it's more the better. Collapsibility, if the vein is collapsed, you will find it difficult to insert the IV line, the centrovenous line. For that, you can just give a volume load, the fluid load to the patient. It will distend the vein, and then you can try to insert your central venous line. Position relative to artery. Oh yes, that's very important. Like for example, let me explain it. Like for example, in the neck, internal jugular vein lies lateral to the, just slightly lateral to the common carotid artery, right? Carotid artery. So, but sometimes it happens that the internal jugular vein, there's slightly variation in its location, and it just and you can find it anterolateral to the artery. So artery will be just a bit posterior to the vein. If you encounter or if you come across such situation, try to avoid this vein, then try some other side, because there are very much chances that you will, or your needle may prick the artery instead of the vein. Like for example, you can choose the femoral vein instead, because femoral vein does not lie anterior or slightly anterior to the artery. Femoral vein lies medial to the artery, right? Just keep these tips in the mind, and I hope you will not encounter any complication. About patient factors, if patient is having coagulopathy, try to avoid subclavian vein, because of then you will not be able to compress it. If there's coagulopathy, you can also avoid internal jugular vein because of the very much closer presence of nearby carotid artery. If patient is having coagulopathy, just go for femoral vein. Respiratory status, if the patient has any kind of respiratory pathology, just avoid subclavian vein. You can approach the other two veins. History of surgeries, if there are history of surgeries on the neck or chest, just avoid the subclavian and internal jugular and go for femoral, right? Okay, now about the location, different sites and different veins and their pros and cons. I will just quickly go through this. I hope most of you have already familiar with these things. It's just a repetition, but it may be something new for our juniors over here. So let's have a quick look. Okay, now there's internal jugular vein, femoral vein, and subclavian vein. Now, as you can see, for internal jugular and femoral vein, we use the probe in short axis. Short axis is also known as a transverse orientation, transverse axis. And then for subclavian vein, we use long axis. Long axis means longitudinal orientation of the probe. Now, why internal jugular vein is better than subclavian? Because the bleed, if there is bleeding, it can be controlled by applying the pressure. Malpositioning, but yes, as I have already told you, that there may be chances of anterolateral positioning, but it's not, but it's rare. There risk of pneumothorax, not as much as in the subclavian. So everything has some pros and some cons, some pros and some cons. So it is most ultrasound guided. It's mostly compatible with the ultrasound guidance, under ultrasound guidance. Coming to its some disadvantages, there's risk of carotid artery puncture. Pneumothorax is possible, not least likely, least likely, it's not just impossible. So pneumothorax is also possible. Difficult to pass venous catheter when there is tracheostomy, and difficult to pass, and do not try on that side when you know that patient is having pacing wires. In such situations, just avoid internal jugular vein and go to the other two options. Okay. Femoral vein, it's easy to find, no pneumothorax, preferred side. Yes, this is very important point. Just keep this in mind. In a situation of trauma patient, in any situation when there is an acute emergency and you don't have time to risk, you don't have extra time, just go for femoral vein. It's the easiest one. It's the very easy to approach. Just put your probe on the leg and just pass. Because and of course, when the CPR is going on, you won't be having any chance to pass the internal jugular subclavian. So when they're doing the chest compressions on the chest, of course, then the femoral vein will be preferred for the central catheterization. It has fewer bad complications, but not but the bad ones are actually the bad ones because they're high risk of infection, risk of DVT. It's not good for ambulatory patients, and there is no CVP monitoring with this. Now, coming to the subclavian, it is the most comfortable for the conscious patients, right? And they're low risk of thrombosis and they're low risk of infection. But there are high risk of pneumothorax, there is high risk of arterial puncture, and sadly, you cannot compress it if the artery is punctured or the vein is punctured and you are unable to railroad the catheter over it. It would be bleeding, hematoma over here, and you will not be able to compress it. So just avoid in such situations. And it should not be attempted in less than 2 years of age. In these situations, we sometimes we go for other veins. And as I've already mentioned, the vein is non-compressible. So what is this? These are the central venous line. This is the non-tunnel. This is the tunnel catheter. We have experts today with us, and they will, at the end of my lecture, they will be, we will have their remarks on the tunnel catheter, non-tunnel catheter, PICC lines, and we will have their comments on it. Okay, now just unpack your CVP line, and you will just get all your splice on the table. It seems very complicated, like I don't know what is this, what is that, but this is a very simplified picture of a CVP central venous catheter set. As you can see, two plunger syringes are here. We have wire here, guide wire, the dilator, and the CVP line. This is a single lumen CVP line. We have double lumen, triple lumen, quad lumen CVP lines. Now about the internal jugular vein. Just briefly, this is the okay. Now over here, this is just like anatomy of the internal jugular vein. This is on the lateral side to the common carotid artery. Over here, or on this side, you can see behind sternocleidomastoid. This is the internal jugular vein, and as you can see, it lies anterolateral to the carotid artery. So it's very tricky site. It's a tricky vein. And you can put your probe just like that in the transverse orientation. This is the position of the patient lying supine, then make it Trendelenburg to 10 to 15 degrees, head rotated to the opposite side. Operator should be standing on the head side, and the ultrasound machine should be over here, just in front of the operator, with all the splice over here on the table. That's what you will get when you place the probe. The transverse orientation of the probe on the neck. And this is smaller one. This smaller one, this is carotid artery. Surprise, surprise. And this the bigger one is internal jugular vein. For those who have never seen internal jugular vein on ultrasound machine, just have a look. It looks like this. The beautiful, round, large internal jugular vein. And this is small carotid artery over here. So this is a very bigger structure. You cannot miss it. So now over here, this is the orientation of the probe. This is the needle direction. This is the out of plane approach. So you will see just a smaller dot, and the tip of the needle will appear as a dot inside the internal jugular vein. Now about the subclavian vein. Subclavian vein lies, you can say, like in the horizontal axis, the transverse axis of the chest, in the chest, just below the clavicle and the first rib. So you put your probe in the longitudinal axis of the vein, and then you will have the whole length of the vein in front of you. And in this situation, for the subclavian vein, the two things that differ from the internal jugular vein are First, the probe orientation is in longitudinal direction, and you use the inline approach. And you will be having the whole length of the vein, and you can visualize your whole length of the needle as well. This is another orientation, as you can see. The probe is lying on the longitudinal axis of the vein over here, and needle is being inserted by the inline approach. So you are having the whole length of the vessel in front of you. About the femoral vein. Femoral vein lies medial to the femoral artery, and this is the nerve. The patient should lie supine, and this is the orientation of the operator over here. Ultrasound machine in front of him with all his plies. The orientation of the probe is transverse to the vein, and we will go with the out of plane technique. Like, it's very clear over here. The orientation of the probe is transverse, and the needle insertion is out of plane. So this is artery, this is vein, and the needle will appear as a dot. Now this is the Seldinger technique for central venous insertion. The first step is the needle, the needle insertion, that is the tracer needle. Then step 2, you pass the guide wire. You just insert the dilator and dilate the vein. Then you railroad the whole catheter over the guide wire, and slightly you just, as you can see the arrow here, you have to slightly start pulling back the guide wire so that it may not accidentally slip into the vein. And when you when the catheter is inside the vein, you just remove the guide wire, and then you stitch, apply 2 stitches to the central venous line with the skin. This is this is a demo on a patient. The brachiocephalic vein is being catheterized for the central venous catheterization. This vein is being used for catheterization in a small child. As you can see, this is obvious from the picture. Now over here, as you can see, the probe is placed in the longitudinal orientation of the vein. So the whole length of the vein can be seen. The needle is being inserted from the in-plane approach. So the whole length of the needle can be seen. Then the catheter is passed, the guide wire is passed, and then the catheter is railroad over here, as you can see, and then the needle is, and then the catheter is stitched to the skin. Now the troubleshooting, very important part. You can come across certain situations. Let's have a look on them one by one. Tenting. Now, as you can see, it's a GIF. I hope you can see this. The movement of, yes, you can see this. This is the tenting. Tenting is, it simply means that your needle tip is at the right place and you are about to prick the vessel. This is a benchmark drill tip making indentation in the anterior wall of the vein. But wait, if you are unable to see the needle tip inside the vessel after tenting, it may mean that the anterior venous wall tenting lead to posterior venous wall penetration. How come? If you continue to advance the needle with the same force and angle, especially if the vein is superficial, small, or not well supported by the surrounding tissue, the force can cause the needle to suddenly pierce the posterior wall. So you have to be very, very careful. If after reaching this point, if you are unable to visualize the tip of the needle inside the lumen of the vein, then that's very like a very risky situation. You have to reassess, just withdraw the needle and don't go further forward. Now, this is a very beautiful slide. I hope you can see the jiffies. Yes, you can see this. So this is over here on the right side. This is we're using the color Doppler, or you can say the color flow. and the blood is flowing, the vessel is patent. But on the left side, you can see there is a white shadow inside it. It is a thrombus. If you ever come across this situation, do not try, do not attempt catheterization in such vessel. Just avoid it. Choose some other vessel. Okay, this is something happened. What is this? Can anybody just identify what happened here? Okay, can anybody just comment on what is this? Actually, this is a guide wire. So it has just crossed, accidentally dislodged, and accidentally slipped. And it's the whole length of the guide wire inside the heart and under the skin. So it is through and through. This is a picture of a real, this is something we just came across a few months ago. And that was something happened, unfortunate event. But fortunately, the patient was all right and there was no complication, thank God. And we just took the help of cardiologist. And cardiologist did what? He used some of his angiography instrument. We have vascular surgeon here, so we will take his comments, and we will also take comments from Dr. Amir Furkan. He is cardiothoracic anesthetist. And what's happening here is they use some angiography tool, and they just hooked around the guide wire from the femoral vessel side, and just they pull it out from that side, the guide wire. So that was it. So that was all about the central venous line. Just last slide about the PICC line. What is PICC line? PICC line is a peripherally inserted central catheter, inserted typically above the elbow and guided through the vein until the tip reaches the superior vena cava. Its placement, it most commonly in the basalic vein, less common cephalic and the brachial. And because of their smaller or sometimes tortuous route in the children and infants, we go for long saphenous vein. Now, PICC line versus, and yes. Something else about that, about the PICC line. There are unpaired and paired veins. Like unpaired veins are basalic and cephalic, and the paired vein is a brachial artery and brachial vein. So for the beginners, it's a tip for them. It's a key feature to avoid. Just do not try on any paired vessel. If you want to insert a PICC line and you're a beginner, it's totally fine. Go with the basalic vein. It was the most commonly used vein for a PICC line. Now about the PICC line versus CVP line, CVC. Both PICC line and central line provide long-term IV access, but the choice between them depends on factors like patient's need and the type of treatment, and also the healthcare provider's preference. And we will also have comments on the preference of the PICC line and the CVC line from our experts in our question answer session. All right, so that's all, but that's not all.